Okay, so welcome to Molecules to Mindset, the podcast where science meets everyday life. I'm your host, Iwama, and together we'll explore the fascinating ways science and healthcare touch every part of our lives. From the molecules that make up our bodies to the thoughts and attitudes that shape our experiences, we're here to dive into it all. Every episode will tackle the topics that matter to you. We'll break down scientific topics and you basically put it into something that can relate to all of us and something that we can all use. We'll chat with experts, share real life stories, and discover how health and science are not just topics for researchers and doctors, but are integral parts of our daily lives. Whether you're looking to understand more about your own health, interested in the latest scientific discoveries, or just curious about how the world works, Molecules to Mindset has something for you. So today, I'm very honored to have Dr. Iwama on the podcast. Dr. Iwama's journey in medicine began in 1974 when he pursued a Bachelor of Science degree at the University of British Columbia, also known as UBC. By 1978, he'd earned his Doctor of Medicine from UBC, marking the beginning of a remarkable career in healthcare. After completing a one-year rotating internship at the Ottawa Civic Hospital in 1983, Dr. Iwama established his own family practice in Surrey, British Columbia. Over the years, he not only provided care in his clinic, but also took on roles in the hospital, looking after his own patients and assisting in surgery. Early in his career, Dr. Iwama also served as an emergency physician, bringing critical care to those in need. Dr. Iwama also had a busy obstetrical practice, delivering many babies, some of whom have remained under his care for over 40 years. In 2003, Dr. Iwama transitioned to a new chapter in his career, working as a palliative care consultant at the Surrey Memorial Hospital until he retired from hospital work. Most recently, in December of 2023, Dr. Iwama closed his family practice and embraced a new role as a locum, where he continues to practice medicine by stepping in for doctors on leave. With decades of experience in family medicine, emergency care, obstetrics, and palliative care, Dr. Iwama brings a wealth of knowledge and insight to our conversation today. So welcome, Dr. Iwama. It's a pleasure to have you join me today.
Oh, it's a pleasure to be here, Ivani.
Perfect. So with that, we can just get started. So to begin, I thought that we could start off with some questions more so about your career to get to know you a little better. So I was wondering if you could please share the journey that led you to pursue a career in medicine and what were some of the key inspirations or moments that influenced that decision and what specifically drew you to become a general physician?
Well, early on, I used to read great stories, and one of the stories that really sort of encouraged me to even think about pursuing medicine were the stories of Sir Wilfrid Grenfell, who was a medical missionary to the northern tip of Newfoundland and the coast of Labrador, and his stories about how really he forsaken his own comfort to meet the needs of people, medical needs of people. But here, he's a fantastic man in that he not only met their medical needs, but he realized that they lacked proper nutrition. So he started greenhouses and farms and started collecting clothes for people and donations. So he was kind of this all-around physician. But he was the person that really piqued my interest in medicine. And in my fourth year medical school, I was very fortunate and blessed to go up to St. Anthony, Newfoundland, which is the northern tip of the Northern Peninsula, to work at the hospital that that Sir Wilfrid Grenfell set up in St. Anthony.
Wow.
And I was part of the working in the hospital doing surgery and also the outpatient clinic. But really exciting was I was part of the air ambulance team, team would be myself and a pilot, and we would fly to the coast of Labrador to little towns where there were no roads to. The only way you can get in is by boat or float plane,
Wow.
and we would go pick up sick patients and bring them back to the hospital in St. Anthony. And then 3 weeks ago, now that I've finished my career and I'm doing locums, my wife and I went back to Newfoundland and I took a long drive up to St. Anthony and revisited the hospital, which really was kind of a full circle at the two bookends of my career,
Mhm.
to work in the same place that was inspired by the man who really inspired me to be, a physician.
Mhm.
But thinking back on my choice of becoming a physician, it was the best choice in my life. There's very few jobs where you can get pure science and apply it uh, to the benefit of mankind.
Mhm.
And it's a career that you have to read a lot. You have to learn a lot every single day. You get to put what you learned into practice. You get the most important things. You get to connect with people at
Mhm.
their deepest needs,
Mhm.
and not all the time you can help them. Not all the time you can cure. But if you allow people to feel like they've been understood and they've been heard, that's part of the healing. And
Mhm.
so healing in medicine doesn't always mean curing,
Mhm.
but healing can be sitting with people in grief, sitting with people who are dying, sitting with people who you have nothing else to offer. So those kind of things really guided me into my choice to become a physician.
Yeah, I think that that's interesting that, you also brought up the point that, like healing someone is not curing exactly with like a medication or something. It can be, simply like providing a listening ear or just like
That's right.
being there for
Yeah,
them. Because I feel like, I mean, obviously I haven't had the same experiences of you, but just from my interactions, um, building connections with a lot of older adults that I do volunteering with, sometimes a lot of them like face a lot of isolation and loneliness, like being in homes for the elderly specifically, and just providing that listening ear. They're so appreciative of it, and I'm so happy to provide that. So it's nice to hear that you also feel the same way about that.
yeah, yeah.
Okay, great. And that's also interesting that you also brought up a rather holistic perspective on healthcare, when you were brought up the missionary who inspired you,
Yeah,
how he addressed
yeah,
different facets. That's super interesting.
yeah.
Um, I was also wondering if you could walk us, like, can you walk us through a typical day in the life of a
Sure.
general physician?
Yeah. So for 42 years, I had my own practice, and I closed my practice in December of 2023.
Mhm.
And since then, after a little bit of a break, I came back to help to kind of give back to medicine by replacing doctors who really needed a break. And I'm doing locums. But let me walk you through a typical day when I had my own practice.
Okay.
I would be in my office by before 6 a.m. every morning. Okay.
Oh.
And the reason why I do that is because I saw my first patients at 7 o'clock.
Hmm.
Now, I know that sounds a little bit strange, but I've always seen my patients very early in the day.
Hmm.
I love mornings. I'm a morning person. And my patients really appreciated being able to see me before they went to school or before they went to work. And they didn't really have to take a lot of time off to come and see me. So I would always see my first patient at 7. But between 6 and 7, I would go through my patient list for the day.
Hmm.
I would, if somebody was coming in to review their blood work or their ultrasound or their X-rays or CT scans, or to go over who it's maybe a patient I sent to a specialist, I would take that 1 hour and read through their lab work, their imaging studies, their consultations, so that when the patients did show up for that day, I was prepared, and that way I didn't have to look at the computer together with a patient and be surprised at some results together. I always like to be prepared,
Hmm.
and my patients really appreciate that. And I used to work from 7 till about 12:30, seeing patients. And then I would dedicate the afternoon to a new area of medicine that arose after the COVID pandemic was with telemedicine. And so these are people who may have a hard time coming in to see me, or they have issues that I could handle over the phone. So I did kind of a hybrid practice where I saw patients physically in the office in the morning and did telemedicine, in the afternoon. Um, in my earlier days, when I used to attend to my own patients, I would work in the morning and work in the hospital in the afternoon, either in the emergency department as an emergency physician or assisting in surgery, or in the last 15 years before I retired as a palliative care consultant, I always maintain a general practice in the morning, just to keep my hands into acute care medicine. I think as a palliative care physician, it made me a better palliative care physician to be a family doctor,
Hmm.
and it actually made me a better family doctor to be a palliative care uh, physician. So I kind of kept those two things in balance. So it was a full day, and my day would end by 5 o'clock, and typically in the evening I would do some charting and all that. So it was a very, very full day. Life is a little bit different as a locum because I don't have the longitudinal responsibility of patients. All the patients I see actually belong to another family doctor. I'm there to help. I'm there to do short-term acute things that I can help while their own doctor is away.
Right. So you kept your days pretty busy with different things. So in the
Yeah,
morning, you had your steady routine of going into your own practice and then changing it up by going into the hospital later on in the
that's
day.
right. That's right. Yeah.
That's interesting. So how did you prioritize and manage the variety of patients and cases that you encountered throughout the day? Because that must be very busy transitioning from a hospital to your own practice or vice versa.
Right. So I have, as in most general practices, do you not only have acute issues like somebody with a fever or sore throat, or they cut their hand or whatever. But I had a good number of people in what I call chronic disease, diabetes, hypertension, congestive heart failure, chronic renal failure, asthma, COPD. So you would organize these patients so that they would come in on a regular interval. I have
Mhm.
my diabetic patients coming in every 3 months,
Okay.
every 3 months to get their blood work done, an important blood work called the hemoglobin A1C. Get that done every 3 months. That way I could see them. I could check their blood pressures every 3 months. I could listen to their heart, listen to the lungs to make sure that they didn't fall into any complications of diabetes. Be a good chance for me to remind them that they had their eyes checked, once a year. So with chronic disease management, you have a a regular cycle that you develop with your patients. But on top of that, you have to deal with the acute things that occur from day to day that the patients need to see you, as soon as possible type of thing. And so, after over 40 years of practice, you fine tune the prioritizing, which
Hmm.
is really important for time management.
Hmm. Right. I see. So, like prioritizing like whichever one is most serious at the moment, whether that be acute or chronic. I see.
That's right. Yeah.
Okay. Um, and I was also wondering if you could share a memorable experience where you felt like you made a significant impact on a patient's life.
Yeah. Well, I can share something that had an important impact on my life.
Okay.
And before I became a palliative care physician, I would still look after my own patients who were dying.
Mm.
And just before I had decided to do a shift in my career, I was caring for this one man who had incurable cancer with metastases in several parts of his body. And he had decided he didn't want any more acute aggressive treatments or
Mhm.
investigations. And that his wish was to die at home, not in hospital. Because at that point in time, we didn't have hospices. That
Mhm.
kind of came on later.
Mhm.
And so I committed myself to this gentleman and his family that I would care for him at home. But thankfully, his house was on the way home from my office to my own house.
Mhm.
And so every single day after I finished my busy day, I would drop by his home and visit him. And by now he was bedbound. And I would go up to his bedroom and just sit and listen to him and listen to his life story.
Mhm.
And it was a good time for me to interact with his family.
Mhm.
And my relationship with this man grew deeper and deeper because now I had the time to sit by his bed and just listen to him.
Mhm.
And we no longer talked. We talked a little bit about pain management and about how end of life would look like. But most of the time, I would be listening to him and to hear his story.
Mhm.
And, when doctors take time to listen to patients' story, their lives become enriched, the doctors' lives become enriched. And I still remember the night that he did pass. I got a call. It was late at night, and I drove to his home. And now his whole bed was surrounded by all his family members, his kids, their spouses, their grandkids, and his patient's wife. And they were singing. They were had strong Christian faith, and they were singing his favorite hymns, and just being with him. And you know what? He died peacefully. He took his last breath when I was there.
Mm.
And I spent some time with the family. And I still remember that night. It's just like yesterday. I stepped out in the cool night air and I looked up and the sky was clear and there were stars and there was a full moon. And I looked up at the sky and I said, you know what? This was so meaningful for me. I actually benefited. You know, the patients, my family might think they benefited because I came to his
Mhm.
house every day, but you know, where I wanted to go to his house every day
Mhm.
to get to know this man. And after he had passed, and I stepped out in that cool evening sky, I decided at that point, this is what I want to do for the rest of my career. I wanted to add a new facet to my career in medicine by studying and specializing and become board certified in palliative care medicine. And that's my story about how I shifted my career into a type of medicine that ultimately became very meaningful for me.
Mhm. I understand. So when you shifted in your care to palliative care medicine, were you doing that in addition to your own practice as well?
Yes, I kept my practice going every morning. Yeah, and I spent the afternoon doing palliative care medicine until the COVID pandemic hit, and
Mhm.
we were all kind of forced to do things differently. And that's when I retired from palliative care medicine and did a hybrid practice of going back to just general practice, but then the afternoon where I would spend time in the hospital, I spent in telemedicine, which we all had to do during the COVID pandemic.
Right. So I can imagine that, um, interacting with those patients, those are pretty heavy interactions,
Yeah.
that you would have to deal with. So how did you maintain a positive well-being throughout, working in palliative care where, you see a lot of your patients taking their last breath?
Yeah. You know what, Ivani, I come from a little island of Okinawa. It
Mhm.
is the island of one of the longest living people in the world.
Mhm.
And one of the concepts that people have identified to keep Okinawan people living long is this concept of ikigai.
I've heard of this.
Ikigai is a Japanese Okinawan word
Mhm.
that really translates into purpose, purpose, almost the purpose of your breath.
Mhm.
And there's three concepts of ikigai. And number one is to do what you love.
Mhm.
Number two is to do what you're good at. And number three, do what the world needs.
Mhm.
And in palliative care medicine, in any form of medicine, I just find that if you take that approach of doing what you love, doing what you're good at, and doing what the world needs, it will give you joy
Mhm.
and joy in your work. And when you have joy in your work, you can keep going for quite a while. The
Mhm.
other ways to really maintain good mental health amidst a busy schedule is to make sure that you draw some pretty firm boundaries
Mhm.
um, around you. One of the things that I learned after 40 years, during my 40 years of medicine doing chronic disease management, is not to own your patient's problems. One of the reasons why patients burn out is because they absorb their patient's problems as their problem.
I see.
That's not saying you don't have any compassion. What you have to do in a compassionate way is to inform the patient, listen, you have diabetes. I don't. This is your disease. It's not my disease.
Mhm.
My job is to equip you with every possible thing that I can provide to you so that you could manage your own disease. I'm
Mhm.
there to help anytime, but I will not own your problem.
Mhm.
And I think when you draw that type of a boundary, the patients appreciate it because they see me as an educator, not somebody to take their problem away.
Mhm.
Can't take in most cases, you cannot take their problems away.
Mhm.
But the best thing a doctor can do is help them manage their own problems. And
Mhm.
when you do that and you set those boundaries and the patients will respect those boundaries in regards to their expectations of you, and you will be healthier in that you're able then to provide much more compassionate care because you have more to give because you've kind of saved yourself that way, right? But I know of colleagues who are burdened and burnt out because
Mhm.
they didn't draw those boundaries, and every person's patient's problems became their problems.
Mhm.
You can't do that. You can't bring your patients home with you, right?
Right. But I can imagine it may be difficult to develop those boundaries, when you're first starting to practice, because as a doctor, you have to show so much compassion and empathy. So
Yep.
I can
Yep.
imagine that it took several years maybe for you to
Well,
develop.
you know what? The thing is, I get a chance to mentor some new to practice physicians in my new role as a locum in a large clinic, and
Mhm.
I keep telling them, which is a novel idea for some of them,
Mhm.
that you have to draw boundaries. You can be absolutely compassionate, and the patients will feel well cared for, like they're understood. But you have to really define your role as a physician is
Mhm.
not the owner of your patient's problems,
Mhm.
but to be an educator to help them manage their own problems.
Right.
I think really that translates to things even outside of medicine.
Mhm.
You know, when you have friends and colleagues who are going through some issues, you can be compassionate, but I think it's wrong to own people's problems as your own.
Yeah, I understand. I understand how that could be very like tiresome, and a lot of the physicians,
Yes,
especially
that's right.
that a lot of physicians like under. I mean, we'll get into this next, but especially since there's a shortage of physicians in BC, and
Yeah,
taking on all those problems, I can imagine how that would be very taxing. So it's good
yeah,
that you developed
yeah,
those boundaries. But speaking of that, I thought that that would actually segue perfectly into the next topic of healthcare shortage issues.
yeah.
So in British Columbia, accessing primary care services, particularly in remote and underserved areas, it possesses a significant challenges due to the factors such as geographical isolation and shortages of healthcare professionals. And residents of these regions often face barriers to receiving timely and comprehensive healthcare, leading to disparities in healthcare outcomes. And given this context, what innovative solutions or models do you think um, could be implemented to address these issues? I know that you talked about how you were involved in telemedicine, but maybe aside from that, or you could talk about telemedicine as well, do you think would be a good, may put in quotes, solution to this problem that we're facing?
Well, Ivani, there's no simple answer to the crisis we're facing, or
Yeah.
else it would have been solved by now,
Yeah.
right? There's an absolute lack of physicians
Mhm.
because of the growing population.
Right.
And our population is growing faster than the proportionate number of medical school seats.
Mhm.
And there's a couple of things I think that has factored into that. A lot more medical grads now are choosing other specialties other than family medicine.
Mhm.
They're choosing surgical specialties or medical specialties, and so therefore the number of residents that are choosing family medicine is getting less.
Mhm.
And I think there's several factors about that because already they see that there's an issue with primary care and you know how taxing it is and how there's a high level of burnout among family physicians because of the kind of work that we do.
Mhm.
So that would be a negative, like that's a deterrent for
Mhm.
somebody considering family medicine, right? There's always been a income disparity between specialties and family medicine, and I think that plays a role in people's decisions about, you know, what they really want to do in medicine. So there's been a whereas when I was in medical school, there's a large number of our class that were going to go into family medicine.
Mm-hmm.
In fact, a lot of people practice family medicine even before they chose their specialties,
Wow.
which really is a wise way to do it, because how does a young medical grad know what a day in the life of an ophthalmologist,
Mm-hmm.
dermatologist, or an internal medicine specialist or urologist is unless you're actually in medicine practicing? And as a family doctor, you get to understand, oh, that's what this guy does for his job, and what that's is what this special. I want to do that, and therefore make a choice, right? That way. So a lot of times, in situations like when I graduated,
Mm-hmm.
a lot of my class actually went into family practice after a rotating internship. And then some of them, most of them stayed in family medicine, and some of them made a choice to specialize after that. But these days, from the get-go, a lot of medical grads are not choosing family medicine. So it's not a lack of the number of doctors they're graduating, it's the relative lack of family practice
Mm-hmm.
physicians that they're graduating from residencies. That's number one. Number two and I feel badly for people that live in remote areas. It's hard to encourage somebody, a new grad, a
Mm-hmm.
new brand new grad, to go into remote areas, because in these remote areas, it's a lot of times you're on your own,
Mm-hmm.
and without a lot of support. And so it might be a little bit daunting for a new grad to face those kind of situations. And thirdly, I think we have to redefine what primary care looks like. In the old days, primary care meant a family doctor.
Mm-hmm.
The family doctor would then uh, use the help of community nurses or physiotherapists or occupational therapists, whatever, right? But I think what we need to do is redefine primary care not being so much led solely by the family physician, but a more
Mm-hmm.
team-based approach. I heard of a initiative actually of somebody I know who is a paramedic, and they're trying pilot projects in smaller remote areas like Boston Bar, where the paramedics, um, who are not used for, they're not going out on a call
Mm-hmm.
24/7.
Mm-hmm.
So rather than sit in their stations waiting for a call, they're actually doing community outreach.
Oh,
So
wow.
they're going in with machinery that
Mm-hmm.
can be through Wi-Fi, through the internet, going into a central area. So they're actually in the patient's home with chronic disease like COPD, emphysema, post-stroke patients who have a hard time mobilizing and accessing care. They're actually in the home. They're putting their blood pressure cuffs on. They're
Wow.
having a listen with these new kind of stethoscopes that their sounds can be transmitted through the internet into
Oh,
a physician at a central station.
that's so cool.
So, so a physician at a central station can actually access five communities that have these
Mm-hmm.
paramedics who are in the homes of
Mm-hmm.
these patients, and actually having to listen to their heart sounds, listening to their chest as
Wow.
if they were listening to their chest, getting their blood pressure readings done over the internet, getting blood oxygen saturations, and even paramedics drawing blood work and having them transported to a local lab. So that's one of those initiatives that are redefining that a physician doesn't need to go into a home of every home of a patient who can't come to them, is using other members of the paramedical field,
Mm-hmm.
to access primary care for them.
And I think by like collaborating all together, that could also reduce a lot of the burden that the physician feels too. And like now they don't need to go to the patient's help. Now, other people can help them and assist them. So they have more free time to, do other things that they need to do as well. I think that's really
Well,
great.
Ivani, when I first started my practice, we didn't have diabetic nurse educators.
Hmm.
And so I would have to do all their diabetes teaching.
Wow.
If somebody needed to be started on insulin,
Hmm.
I'd have to get the patient to write a prescription for insulin and get some syringes and teach them how to give themselves their own insulin. I would have to do all their diabetic teaching, their eye care, the foot care, and being cognizant of their heart and kidneys and so on and so forth, and how to monitor that. That was a lot of burden on family doctors
Mm.
because we didn't have diabetic nurse educators. We didn't have, at that point, pharmacists weren't doing injections and things like that. But now we have community-based nurses, we have diabetic nurse educators who can probably do a far better job than I used to be able to do because they have the time
Mm-hmm.
to do there, to sit with that patient and go over their diabetes from A to Z, from head to toe, and provide much better care. So we have to redefine what primary care looks like. And primary care is moving toward team-based care.
Mm-hmm.
Now, there may be a physician who is, the captain of that ship to help direct where they're going, in regards to the medical point of view,
Mm-hmm.
but to utilize pharmacists to do medication reviews to make sure that there's no drug-to-drug interactions, to make sure is this the most cost-effective way of these medicines?
Mm-hmm.
Like I don't have all that knowledge of a pharmacist in
Right.
my head,
Mm-hmm.
and I don't have the time to go over all the issues a diabetic needs to know about. But
Mm-hmm.
with diabetic nurse educators and with pharmacists now, being empowered with more things that they can do and teach, why not utilize that to provide the ultimate thing, Ivani, is to provide better care
Mm-hmm.
so that nobody slips through the cracks, so no issue slips through the crack. And if you do a team-based approach and
Mm-hmm.
use these other people, I think you provide better care and you can have a greater amount of care, throughout the province. But I think the province needs to put the Ministry of Health. They have started, and a good job they've started that, but
Mm-hmm.
they need to put more focus on the fact that primary care is going to look different.
Right. So just to reiterate everything, so it's a twofold issue between population increasing,
Yeah,
more medical students graduating, choosing specialties. We need to redefine family care as, or sorry, primary care as team building,
yeah,
and you're saying, remote areas, it's
yeah.
it's kind of hard to persuade incoming grad students to practice there. So I know the government has started some sort of initiatives to
Yeah.
um, promote like, people working there, maybe that may be through payment, but it is difficult, especially, if you don't have any family ties, to be alone in a remote area. I feel like that would be quite difficult. So.
Well, it's just the remoteness may be difficult for a new grad to go out there.
Right, right.
And if he has a choice, because there's a need for family doctors everywhere,
Hmm.
if he has a choice to practice close to his family home,
Yeah.
the city, versus going far up north, unless there was enough of an incentive for them to go up there, it's pretty difficult to go up there. Plus, as I mentioned, it's pretty daunting in regards to the challenges that they'll be facing in regards to uh, really sometimes being the only doctor, maybe in a large geographic area, to be on call 24/7, and to really deal with a lot of medical issues that maybe in an urban setting a specialist would take care of.
Yeah.
I still remember when I first started my practice back in 1983 at Surrey Memorial Hospital. Surrey Memorial Hospital was a small regional community hospital. It
Okay.
was run mainly by family physicians.
Hmm.
We had a few specialists. We
Hmm.
had a smattering of surgical specialists because a lot of them were north of the river into Vancouver, Burnaby, and New Westminster.
Hmm.
And a lot of them didn't want to cross the bridge to, serve as patients at Surrey Hospital. So as a consequence, us family physicians had to take on the role of doing what specialists would do in a bigger city in an urban center. So that is akin to a new grad now going to a remote place. There
Hmm.
may be a hospital there, but you and maybe a handful of doctors, maybe the only doctors
Hmm.
servicing a huge geographic area with a large population, and that itself produces challenges. And one of the things that would really help is to use older physicians that have retired like myself,
Mm-hmm.
as mentors, to be uh, as close as a phone call or a video call to avail ourselves to say, for a young physician to say, hey, I'm having difficulty handling this patient who has congestive heart failure and chronic renal failure. And if I treat aggressively the chronic renal failure, I'll worsen his congestive heart failure. If I treat his congestive heart failure aggressively, I'm going to
Yeah.
worsen his renal failure. Help me, right? And I face that as a locum now because I'm in a clinic with a lot of new to practice physicians,
Mm-hmm.
and I'm definitely double their age for some of them. Okay. And some of them have 1 or 2 years of practice. I have 42 years of practice behind me. And so a lot of times when I open the door of my examining room uh, to go in the hallway, there's invariably a young doctor standing there waiting for me. Says, please, Dr. Iwama, can you come into room number 9? I have a patient. I'm having a hard time handling
Yeah.
their situation, which I'm absolutely thrilled and happy to do that. But um, that should, the government should bring in a program
Mm-hmm.
where they use experienced retired or semi-retired physicians like myself to be connected to a young grad who's
Mm-hmm.
willing now to go to a remote geographic area so
Right.
that this person feels supported and they don't feel alone,
Mm-hmm.
that an experienced physician is as close as a video link.
Mm-hmm.
I think that would be helpful.
Yeah, because I know that especially in the Maritimes, like a lot of physicians during the pandemic, they retired, and then certain towns were left without physicians.
Yeah,
And I'm sure that like that physician, like if they maybe they like felt overburdened and they felt the need to leave. I'm not sure what the situation was, but yeah, like having a program like you're saying would be like immensely helpful. And
yeah,
it's stressful because when there's that lack of physicians, a lot of patients are, they go to the emergency room and the emergency rooms are burdened. And it's difficult because not only the Maritimes in BC, but I also know in the prairies, such as Manitoba, a lot of international physicians are coming into practice as
yeah,
general physicians. And I read this one article where this one owner of a practice, she's a family physician herself, but she had to bring in 7 international physicians and she was paying out of pocket. So I can imagine the burden of paying for those international physicians out of pocket, what she must have felt. So getting programs to fund that and incentivize things such as having
yeah,
mentors, like you're saying, would definitely help. So
yeah. So
yeah.
Ivani, when you think of the number of physicians that are retiring every year,
Hmm.
and one of the reasons why they're retiring is age related,
Hmm.
right? But burnout is a real issue.
Yeah.
The burnout comes also because they've had to do excessive administrative work to run a practice, right? But what you're doing is you're losing a wealth of knowledge
Mm.
and experience and wisdom that these physicians carry
Yeah.
that
Hmm.
could help new to practice physicians, not just in urban, suburban, but in remote areas, right?
Hmm.
But don't burden them with administrative
Hmm.
things
Yeah.
and and just cultivate an environment where you could harvest their medical knowledge and wisdom and experience to help new to practice physicians and set up a program where when a physician retires is to say, after maybe a few months of retirement, would you be willing
Hmm.
to mentor this person in a remote or maybe even in a suburban area, remote area for a new to practice physician.
Hmm.
Uh, and that would be, I've always thought of that because I only thought of that after I became a locum.
Hmm.
And as a locum, every day, several times a day, I get asked by a new to practice physician for help.
Hmm.
And I'm thinking, wow, this would be really helpful if it was formalized,
Hmm. Yeah.
you know, and then that way there's a whole army of us
Hmm.
retired physicians that have still something to contribute. They all became most people become doctors because they love practicing medicine.
Hmm.
But what they don't love is the paperwork that a thriving practice brings.
Yeah.
And and our associations have tried
Yeah.
to talk to insurance companies and people like that.
Hmm.
Don't burden our doctors with paperwork.
Right.
But the insurance companies have continued with, if somebody takes time off work for a few days, do you know sometimes they have a 7-page insurance form a doctor has to fill?
Wow. Wow.
You know what I mean? And so the our association have said, don't even send those forms. Just take the doctor's word that this patient was sick.
Yeah.
But you know, those kind of things, Ivani, have
Hmm.
burnt people out. But if you take that factor away, most retired physicians would probably still love to be able to practice medicine in situations where they didn't have a longitudinal responsibility for patients, where patients don't are not attached to you.
Yeah.
And number two, to reduce the administrative burden that have burnt them out.
I think that's such an interesting point because that made me think of another article that I was reading too. Specifically when you referenced remote areas and how it'd be nice to, talk to a mentor. A lot of people have been dabbling with the idea of artificial intelligence and
Mhm.
how a lot of physicians in remote areas, might want to rely on using AI to
Yep.
consult because one, for physicians, it's not that they don't want to collaborate or consult others, like you're saying, if they're overburdened with the paperwork and the amount of patients they have working in a remote area, sometimes it might be nice to use AI. But on the other hand, there are negatives to AI in that it is not always the most reliable source for certain things. So
Yep.
I think that consulting a mentor, like you're saying, would be like a great would be a
Yep.
great thing because it's not like you're burdening, maybe not burdening, but you're not, using someone else's time of a physician that's currently practicing. But you're consulting a mentor who has that designated time for you. I think that's a would be
You
a
know what, Ivani, there's a big difference between wisdom and knowledge.
Mhm.
Knowledge you can accrue from going to medical school
Mhm.
and doing a residency and even AI. There's a lot of knowledge, okay?
Yeah.
That is different than having wisdom.
Mhm.
And wisdom only comes with practicing for many years.
Mhm. Mhm.
That as you practice, you say, you know what, the textbook said this, but this situation doesn't look like the
Yeah,
textbook.
I see.
And so as you practice, and that's why they call it the practice of medicine,
Mhm.
you're always practicing because you're gaining wisdom as you apply knowledge into situations and find out that not everything is textbook.
Mhm.
Not everything is as the professor said it would be.
For
And
sure.
you have to almost carve out your own niche of wisdom from which you're able to help patients, right? So I look at AI,
Mhm.
and AI has its place. I mean, in a few seconds, you can get knowledge, you know, what are the possible causes why this person's skin has turned this color.
Mhm.
Well, AI will tell you, bang, in a few seconds, correct? But what happens if AI says, well, there's 21 different causes of that person's skin turning that color?
Yeah.
That's useless,
Mhm.
right? Too much knowledge is useless, sometimes. But you need wisdom to winnow through all that knowledge to say, in this situation,
Mhm.
in this patient, um, the reason why this person's skin color turned this color is most likely this because I've seen this before,
Right.
right? And also, the textbook said to treat it a certain condition this way.
Mhm.
Well, I have, and it didn't work, but
Right.
I've tried this, and this worked better.
Mhm.
That's wisdom. It's
Mhm.
an accumulation of past experiences
Mhm.
to help you discern what to do right now. AI can't do that.
Right.
AI is just a huge, tremendous bank of information and knowledge.
Mhm.
But what AI will never be able to do is to delve out, is to dish out wisdom that an experienced physician who has 40 years of general practice
Right.
can. Yeah,
Because I mean, you're able to tailor your care specific to each patient's problems that they're facing, and you can bring in your own personal insights to help you navigate that situation. But yeah,
exactly.
I agree. You're it's almost like you're optimizing the care that would be perfect for each patient. Um,
Yeah,
kind of similar to myself, like even if, for example, if I'm doing an experiment, like the protocol might say follow XYZ steps, but I realize that it doesn't work for me. So you have to optimize it to make sure, it works, just like how you work with patients. And
and the reason why you did that is because you tried it before and
yeah,
it didn't work
exactly,
out as well, right? But
exactly.
if you did XYZ here, oh,
Mm,
that worked out better. Well, then you see that goes into your psyche and into your memory, so that the next time you're faced with the same situation,
yeah,
you're going to do this instead of do this, right?
sure.
And that's some of the things. Yeah, maybe AI can work those things out with their logistic algorithms,
Hmm.
but there's nothing that replaces experience.
Right, for sure. I definitely agree with that. And
Yeah,
I don't think it's the most reliable source. So
yeah,
I'm definitely with you on that.
yeah.
Um, we talked about it a little bit, but I was wondering if you could provide some insights about, so if you were to look back on your career, um, what are some of the most significant changes that you've witnessed in family medicine, and how have those influenced your practice?
Okay, well, if I went back to 1983, I was a new grad. Okay, I started my career as a family doctor and an emergency physician. Okay,
Mm-hmm.
you know what? I know this would be hard for you to believe, but in those days, we didn't have the CT scan wasn't invented yet. Okay,
Wow. Okay,
we had
wow.
X-rays. We had X-rays, and ultrasound was just coming into being.
Wow.
We didn't have a lot of tests that we could do. I know that sounds like I worked in the age of the dinosaurs, but that was only in 83, right? And I remember that I still remember when CT scans were just coming in, thinking, wow, this is really something else. We can actually image something in a 3D way.
Mm-hmm.
Well, exponentially, right, all that uh, technology
Mm-hmm.
has grown. It's exploded, right?
Mm-hmm.
Uh, you know, uh, who knew that we could talk to people on our Apple Watch?
Yeah,
That was the thing of Dick Tracy. And well, you don't even know who Dick Tracy was, but
I don't.
he was a cartoon character. He was a detective that he could talk to people on his phone, on his
Okay.
watch.
Okay.
And now we are all Dick Tracys, okay? So I mean, and I know at the clinic that I worked with, these new to practice physicians, their iPads and their iPhones and their MacBooks are very close at hand,
Mhm,
uh, to help them, right?
mhm,
So that technology explosion is, I think, has changed the face of medicine,
mhm.
right? Before, Ivani, we had textbooks.
Yeah.
We had actually textbooks made of paper, right? And if I needed to know something, I would go to my textbook of medicine and turn to the chapter and the page and read up about it, right?
Mhm,
But of course, you have to keep buying new editions because knowledge changes, right?
mhm,
Well, now at the fingertips, any new to practice grad has all of that within a few seconds.
mhm,
The textbook that we use in internal medicine is a classic one called Harrison's.
mhm,
Well, they can have the latest edition of Harrison on their iPhone.
mhm.
That would have been like way beyond our imagination that
Right.
that can happen in the palm of your hand, right?
Mhm,
So, and the kind of imaging that we can do now, uh, it's even like CT scans seem rudimentary now compared to PET scans and SPEC scans and MRIs and the kind of tests that we can do. That in my one career length, I've seen it from having only an X-ray
Wow.
to now really being able to image anything and check anything, right?
Yeah.
There's a dark side to that as well.
Mhm,
I think technology puts a barrier between the patient and a physician, the patient and the attending physician and the patient. In that now there's sometimes you can actually diagnose and examine and diagnose and treat a patient without actually seeing them. You
Mm.
know,
Mhm.
everything can be done through all these scanning and blood work and things like that. But Ivani, part of being a physician is not technology, it's not knowledge. It's about caring for people.
Mhm.
And you know what? The greatest need that patients in hard, dire situations really need, more than technology, more than the latest scan, more than the latest test,
Mhm.
is somebody to sit next to them and listen to them.
Mhm.
And
Mhm.
if patients can come away from an encounter feeling like they've been heard,
Mhm.
they've been understood, I may not have been able to fix their medical, physical problem,
Mhm.
but if I can make my patients feel like they're heard and they're understood,
Mhm.
I think that's half the healing.
Right.
That
Validate them. Yeah. Right.
that's healing. And as we talked earlier in our podcast,
Yeah.
healing is different than curing.
Mhm.
There, the grave reality is there's precious few things that we can heal.
Mhm.
We haven't been able to turn back the clock in regards to making people stop aging, right?
Yeah.
We haven't been able to stop organs from deteriorating.
Mhm.
We haven't been able to stop people from abusing their own bodies through alcohol and drugs and bad behavior, right? But when you find people at their toughest spots
Mhm.
in their life, and you sit down, whether it's at their bedside in a hospital or across the room in an examining room,
Mhm.
and you put all your technology aside and you listen, and patients feel better. They say they feel better. I'm not sure what that physiologically means,
Mhm.
but if they feel like they've been heard and that somebody understands where I am,
Mhm.
you know, you know what? Let me give you an example. When I used to be a palliative care physician, I would be visiting dying patients, right? Now, in some hospital rooms, there's 4 beds in a room that's separated only by a curtain, so there's very little privacy.
Mhm.
And as I was dealing with some dying patient, there would be a patient in the next bed who was equally in a bad situation, and they would have visitors come in, right?
Mhm.
And these visitors then would start peppering the patient with questions, oh, what did the doctor say? And what test are you going to do? And what did it do? Blah, 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 blah. And the poor patient's sitting there and he's dying and he
Mhm.
has to entertain these people, right? But to realize that people feel uncomfortable with silence, A. Number two, they feel uncomfortable just hearing people, right? And 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 so they fill the vacant air with questions.
Right.
Well, sometimes people just need you to sit with them. There's a term called sitting in the ashes with people.
Mhm.
It means when people are going through loss, when they're grieving or they're facing some tough situation, and you don't have the wise word, you don't have the treatment that's going to take care of their problem. You don't have the thing that they need. You know what? Sometimes the greatest gift you can give them is just to sit there.
Mhm.
And let me let me let me end with this situation. I still remember going to see a dying patient,
Mhm.
and he was in hospital for several weeks.
Mhm.
And I went to go and see him, and his wife and his daughter were at their bedside.
Mhm.
And I said to him, "I'm here to help you. What can I do to help you today?"
Right.
And he didn't talk about pain management. He didn't talk about, can you tell me what my next few days of dying are going to be like?
Mhm.
You know what he said to me?
What?
He said, I wish I could get a shave. He'd been in hospital for 3 weeks and he had grown a beard.
Mhm.
And and I could just sense from him he was always this well-kept,
Right.
self-respecting man who one of his values was looking good, right? And he had this scruffy old beard. So he was asking me if somebody could shave him. Like, is there somebody on the ward that could shave him? And I looked at his family, which is his wife and daughter, and both the wife and daughter says, "Well, we know how to shave other parts of our bodies, but we don't know how to shave a man's beard. They've never done that." And when I thought about the nursing station, I thought these nurses are too busy
Mhm.
to shave this man. So I went out and I went to the nursing station and asked for a wash basin and a razor
Mhm.
and a towel and some soap.
Mhm.
And the nurses said, "What are you doing, Dr. Iwama?" I said, "You know the patient in room 37?" He says, "Yes. I'm going to go shave his beard." They said, "You're going to do what?" I said, "That's his greatest need
Mhm.
today. I'm going to shave him." And so I took the water basin, got some warm water, put some soap in there, and I went and I put a towel around his neck.
Wow.
And as I was shaving him, he started to cry. And
Mhm.
his wife and his daughter started to cry. Because you know what? I didn't have the magic potion to take his cancer away.
Mhm.
I didn't have the thing to turn the clock backwards,
Mhm.
but I met his greatest need
Right.
and I shaved him. And you know what? That was the best thing that I could do for him that day.
Mhm.
And that's what patients need. Patients need to know that they're understood, that
Mhm.
this person understands what my greatest need right now is.
Mhm.
And as a physician, you can meet that. And sometimes it's not knowledge, it's not even wisdom,
Mhm.
but it's compassion.
Right.
And compassion is to be able to sit with people in their greatest needs.
Mhm.
And that's why I've been blessed to be a physician, because I get a chance to do that at every patient encounter.
Right. And that, first of all, that was an amazing interaction that you had. It was so great, great to hear that. I can't believe that you experienced something like that. And that patient must have been so appreciative. Um, but I was also wanting to add on and mention, since you were talking about healing and curing, and the difference between those two. So I was wondering maybe if people nowadays, maybe their perception of, healing and curing possibly needs to be altered because you hear on media the cure for cancer, the cure for this disease, and I feel like that puts false perceptions sometimes in a lot of people's heads because I know from my own research that how how detailed these processes are and how they're all integrated into each other within the body. And it's so difficult to really just find a cure, quote unquote, for something. It's better to maybe just treat what they have. And I just feel like putting so the media keep saying, we're gonna cure things. It can maybe give, I don't mean to sound blunt when I say this, but it can give people maybe a sense of false hope. Um, and that might be tough for you as a family physician trying to bridge that gap between the reality versus what, they've been hearing. So
Right.
I can imagine that that would be really difficult to
Do you know
navigate.
what, Ivani? I know this sounds kind of blatant, but everyone dies.
Hmm.
You know why? Because
What?
we can't cure everything.
Yeah.
If even if somebody can be cured of cancer, they might die of a heart attack,
Hmm.
or they die of old age, right? And so, the greatest gift as a physician has is the ability and the opportunity to travel with people in
Hmm.
their journey of life.
Right. Right. Yeah, for sure. I was wondering if we had time for one last question and then we could
Sure.
close it up. Okay, so one last question that I want to ask that I've been personally wondering about because I find it that it's needed to talk about.
Yeah.
So um the hierarchical structure within healthcare settings can
Yeah.
sometimes lead to a perceived power imbalance among healthcare professionals, like we were talking about with the paramedics. And so I know you collaborate with a lot of other team members, like you're saying now, but I was wondering if you could delve deeper into your perspective on this issue, particularly regarding its impact on patient care and interprofessional relationships, for that power and
Okay.
influence.
Tough question, and I think hard to solve because it's generational
Mm-hmm.
in regards to partitioning healthcare to different people, right?
Mm-hmm.
And for far too long, I think they've seen, the society has pictured physicians, as the captain of the ship or, whatever. Um, there has to be this massive shift in people's thinking and psyche, which I think it's impossible to bring to everyone.
Mm-hmm.
But to understand that medicine, to be a physician, is a serving relationship. It's a serving profession. It's not, I'm, I'm not here to lord over you. I'm not here to tell you what to do because you're the patient and I'm a doctor.
Mm-hmm.
What I always start with every encounter, many times every day, is these words: what can I do to help you today?
Mm-hmm.
And if everyone can take that type of attitude, it levels the playing field in regards to whether you're a physician or physiotherapist or occupational therapist or a nurse or a pharmacist or a community nurse worker, whether you're a family doctor or you're a specialist or
Mm-hmm.
you're a subspecialist or you're a super specialist. If everyone can start off their day by saying, what can I do to help you today?
Right.
That brings the level playing field. But that, Ivani, is going to be difficult
Mhm.
because not everyone approaches patients that way. And
Yeah.
I can't change that. You
Yeah.
know what? But I can only change it for me.
Mm-hmm. Mm-hmm.
I can only start with me.
Right.
And I can only start with the people I can mentor
Mm-hmm.
to do the same thing.
Right. Well, I think that it's already been quite a long podcast, and that was an amazing podcast, and I think that should wrap up what we had to discuss
Yeah.
today. So, thank you so much, Dr. Iwama, for taking
Oh,
time to do this.
it's a pleasure.